And now we continue in chapter 52, which is a very busy chapter. And we are going to review diverticular disease among other topics. Okay, let's see how far we go. Hopefully we finish this chapter. Diverticular disease are pouch-like herniation of the mucosa through the muscular wall of any part of the gut, but mostly common the colon. Diverticulosis is the presence of many abnormal pouch-like herniation, diverticula, in the wall of the intestine. Acute diverticulitis is the inflammation or infection of diverticula, right? Itis, inflammation. Pathophysiology review, diverticula can occur in any part of the small or large intestine, but they usually occur in the sigmoid colon, right? We have the ascending colon, the transversal colon, the descending colon, and then we have the sigmoid. After the sigmoid, we have the rectum. So it's in the sigmoid colon. Here you have the picture. Diverticula without inflammation cause few problems. However, if undigested food or bacteria become trapped in the diverticulum, blood supply to that area is reduced. Bacteria invade the diverticulum, resulting in diverticulitis, which then can perforate and develop a local abscess. A perforated diverticulum can progress through an intra-abdominal perforation with peritonitis. So in all the chapter 52, we have been mentioning peritonitis caused by different causes. It could cause by ulcerative colitis, Crohn's disease, a fistula, maybe an ulcer coming from any part of the gastrointestinal, from the stomach. There is a rupture in the mucosal of the gastrointestinal system, and these contents are going to invade the peritoneum, causing peritonitis. Assessment, recognizing the cues when we do the assessment. The patient with diverticulosis usually has no symptoms unless pain or bleeding develops. The condition may go undiagnosed, and the diverticular are more often diagnosed during routine colonoscopy. Why? Because usually it's located in the sigmoid colon, and that is part of the pathway that the colonoscopy is going to review. Ask about intermittent pain in the left lower quadrant and a history of constipation. Why the left lower quadrant? Because it's the pathway of the descendant colon and the initial pathway of the sigmoid colon, and that is the left lower quadrant. If diverticulitis is suspected, ask about a history of low-grade fever, nausea, and abdominal pain. Inquire about recent bowel elimination patterns because constipation may develop as a result of intestinal inflammation. Also ask about any bleeding from the rectum. So we have reviewed the concept tenesmus, right? I wouldn't wait for a patient to have constipation, right? And probably after that, because the patient is going to for the rectum or the sigmoid colon to have a bowel movement, the patient is going to develop hemorrhoids. I'm not going to wait for that. If the patient is telling me that she feels like she has to go, she feels like she needs to go for bowel movement, but after having the bowel movement, she's still having the sensation that more content is inside, you have to pay attention because probably there is a constipation developing. Okay, so pay attention to that. The patient with diverticulitis may have abdominal pain, most often localized in the left lower quadrant. On examination of the abdomen, observe for distension. Yeah, it has to be like a lot of content inside to be noted as distension, right? So that's why a history, proper questions, the right questions, and the history and pattern of the bowel movement are crucial to determine this. An examination of the abdomen observed for distension, guarded movement, and rebound tenderness may be present with peritoneal irritation. We study that, and we have been repeating these concepts all over and over again. And it's important to know the concepts because they are going to be present in all the disorders or diseases that are involved in the gastrointestinal system. If generalized peritonitis is present, profound guarding occurs, rebound tenderness is more widespread, and sepsis, hypotension, or hypovolemic shock can occur. For the patient with a complicated diverticulosis, laboratory studies are not indicated. However, the patient with diverticulitis has an elevated white blood cell count, like in all the diseases we have been reviewing. Decreased hematocrit and hemoglobin values are common if chronic or severe bleeding occurs, and that's the risk for anemia. We know that. Stool tests for occult blood, if requested, are sometimes positive. Abdominal X-ray may be done to evaluate for free air and fluid, indicating perforation. We know that as well. Perforation is indicative when the abdominal X-ray is showing free air and fluid. A CT scan may be performed to diagnose an abscess or thickening of the bowel related to diverticulitis. Also, abdominal ultrasonography. Non-surgical management, part of the interventions, a combination of drug and nutrition therapy with rest is used to decrease an inflammation associated with diverticular disease. So basically it's the symptoms that we are treating, right? Broad spectrum antimicrobial drugs such as metronidazole in conjunction with trimethoprim sulfaton TMC. It's so difficult to pronounce that. Sulfamethoxazole, TMC, or ciprofloxacin are often prescribed. Ciprofloxacin is more common known as Cipro, right? A mild analgesic may be given for pain. Now, patient care, older adult considerations in diverticulitis. Do not give laxative of enema. Teach the patient and family about the importance of avoiding these measures. While diverticulitis is active, provide a low-fiber diet. We spoke about the antibiotics and analgesics. And basically to monitor the quality of the stool, monitor for pain, fever, abdominal distension. Teach the patient to rest during the acute phase of illness. Remind him or her to refrain from lifting, straining, coughing, or bending to avoid an increase in intra-abdominal pressure, which can result in perforation of the diverticulum. Again, it's happened the same thing in all the gastrointestinal disease. You have to avoid this lifting, straining, coughing. All the muscles that are involved in these activities are most of them located in the abdominal area. Nutrition therapy should be restrictive to low fiber or clear liquids based on symptoms. The patient with more severe symptoms is MPO, nothing per oral. Okay. Surgical management. The surgeon performs emergency surgery if peritonitis, bowel obstruction, or pelvic abscess is present. Colon resection with or without a colostomy is the most common surgical procedure for patients with diverticular disease. Let's talk about celiac. Celiac disease is a multisystem autoimmune disease with an estimated incidence as high as 1 in 250 of the world's population. It is a multisystem autoimmune disease, celiac. Patients who have other autoimmune diseases such as rheumatoid arthritis and diabetes mellitus type 1 are high risk for the disease. I will also include any patient with thyroid disease like thyroiditis. Okay, I will include this. If we are checking for a patient with celiac disease, I will review the rheumatoid, if there is rheumatoid arthritis present, diabetes mellitus type 1. Okay, at this point we must know the difference between type 1 and type 2, and thyroiditis. Okay, even if I find somebody with an autoimmune condition, like for example any autoimmune with the skin, let's say, or any type of cancer, okay, I will monitor. It's not in the books, but autoimmune is not related only to certain organs or only to certain areas. Autoimmune is a systemic condition, so I will monitor any part of the body. Celiac disease is a chronic inflammation of the small intestinal mucosa that can cause bowel wall atrophy, malabsorption, and diarrhea. Like many inflammatory disorders, it is thought to be caused by a combination of genetic, immunologic, and environmental factors. The primary complication of celiac disease is cancer. There you go. Okay. Specifically non-Hodgkin lymphoma or GI cancers and nutrition deficiencies. Nutrition deficiencies. Nutrition deficiencies. So a patient that is not having a proper amount of protein, or is having an inorganic type of protein, or is having an excess of carbohydrates or too much fats. Consider fats and obesity a leader cause of inflammation in the gastrointestinal. That can cause cancer as well. When I say nutrition deficiencies, could be not only lack of nutrition, but an excessive, abusive quantity of nutritional intake. Okay. Signs and symptoms with cycles of remission and exacerbation. That's one of the typical flare-up presentations. Classic symptoms include anorexia, diarrhea and constipation, statorrhea, fatty stools, abdominal pain, abdominal bloating and distension, and weight loss. Dietary management is the only available treatment for achieving disease remission. Dietary management. In most cases, a gluten-free results in healing the intestinal mucosa after about 2 years. Gluten is the primary substance in wheat and wheat-based products. Okay, so keep gluten away from the diet. Most important features in celiac disease, of course, we're gonna weight loss. We're gonna have weight loss if we have the diarrhea and the anorexia. Statorrhea, keep an eye on that. Atypical symptoms: osteoporosis, joint pain and inflammation, lactose intolerance, iron deficiency anemia, right? Because of the malabsorption of the nutrients, the iron, depression, migraines, epilepsy. So the abdominal area is considered the second brain in the body. So if we have a disorder, a disease in the abdominal area, in the gastrointestinal, that is going to be affecting our mental status. That's why if we have excessive quantity of the bad nutrition, we're going to have depression, anxiety, migraines, right? Autoimmune disorders, stomatitis, early menopause, protein calorie malnutrition, infertility, and in fact, talking about menopause, patients who are having a bad nutrition or nutrition deficiencies, they are going to have the menopause symptoms more pronounced. Okay, more pronounced. The better the nutrition, the better is going to be the transition from perimenopause to postmenopause. Comparison of common parasitic infections. Oh, this is for the next topic. Okay, let's talk about parasitic infections. We have a table here It's talking about Gardiasis with the Gardia lambia, Amebiasis, and Cryptosporidium. Okay. Um, This Gardiasis is going to cause superficial invasion, destruction, and inflammation of small intestine mucosa. The amebiasis invades and ulcerates large intestinal mucosa. Amebiasis, large intestinal with ulceration. Okay, and Cryptosporidium source is often contaminated swimming pools. I'm not against the swimming pools if they are proper clean, but at this point, with too many viruses, bacteria going on in the world, I will strongly recommend you to be away from these swimming pools, especially if you take a cruise, right? When they have 5 or 7 pools, but there's 8,000 passengers. Common assessment findings for gardiasis chronic phase can last for years. The amebiasis can have extraintestinal symptoms. So it's in the large intestinal mucosa with extraintestinal symptoms, and Cryptosporidium primary diarrhea. Self-limiting health problems in individuals with normal immune system. Okay. So parasites can enter and invade the gastrointestinal tract and cause infection. They commonly enter through the mouth or fecal transmissions from contaminated food or water. This also oral, anal, sexual practices, or contact with feces from a contaminated person. Common parasites that cause infection in humans are Giardia lambia, which causes gardiasis, Entamoeba histolytica, which causes amebiasis, and Cryptosporidium. The primary method for determining which parasite infection is present is through stool analysis. The white blood cell count is going to be very high when severe diarrhea is present. Okay. Assessment. A history of travel to parts of the world where such infections are prevalent increases suspicion for infection with parasites. GI symptoms related to travel might be delayed as long to 1 to 2 weeks after the return home. A nutrition history is especially helpful if several people in a group become ill. The infected, remember what I told you about the cruise, if several people are coming ill, that what happened in the cruise during COVID-19 was not parasites. We don't know, but probably yes. In addition of the COVID-19, the infected patient usually experiences remission and recurrences. Severe amoebic dysentery is manifested by frequent liquid and foul-smelling stools with mucus and blood. Wow, it's a good amount of symptoms together. Frequent liquid and foul-smelling stools with mucus and blood. Fever up to 104. It's no joke. This is a very high fever. Tenesmus, again, as I told you before, when somebody reports tenesmus, probably they are not going to report it verbalizing that word, but they are going to give you the symptoms of tenesmus. Generalized abdominal tenderness and vomiting can also occur. The ulceration of invading amebiasis that occur in the colon can cause pain, bleeding, and obstruction. Ulcerations can also occur in the rectum, resulting in formed stools with blood. Complications are rare but include appendicitis and bowel perforation, of course. Extraintestinal amebiasis can occur without symptoms of intestinal infection. The most common form is amoebic liver abscess, which causes symptoms of fever, pain, and an enlarged liver. The abscess can rupture, and that can result if the infection and complications are not treated. Excuse me. Interventions. What are we going to do? As a nurses, we cannot assess the liver. We cannot palpate the liver if the patient is presenting with pain in that particular right upper quadrant, right? Leave that assessment for the primary care provider. We don't want to cause more problems, or we can rupture anything, right? Let the primary care provider assess the liver. Hand washing is the best way to prevent the spread of parasitic infections. Hand washing prevents everything, period. The patient with severe amoebic dysentery requires IV fluid replacement and possible an opiate-like drug, okay? Because we need to replenish, right, the fluid and electrolytes, and also we need to relieve the pain. Treatment for gardiasis is drug therapy. Metronidazole is the drug of choice. I mentioned before, don't get overwhelmed with the amount of drugs that they are using for different conditions. Try to focus on the ones that are most commonly used, okay? In this case, metronidazole is used for a bunch of disorders in the gastrointestinal. Nursing safety priority. Explain modes of transmission of parasitic infection and means to avoid the spread of infection and recurrent contact with parasitic organisms. Inform the patient that the infection can be transmitted to others until amebicides effectively kill the parasites. Teach the patient to avoid contact with stool, keep toilet areas clean, wash hands meticulously with antimicrobial soap after bowel movements, maintain good personal hygiene by bathing or showering daily, avoid stool from dogs and beavers. Advise the patient to avoid sexual practices and allow rectal contact until drug therapy is completed. All household and sexual partners should have a stool examination for parasites. If the water supply is suspected as the source, a sample is obtained and sent for analysis. Multiple infections are common in households, often as a result of contaminated shared water supplies. Well water and water from areas with inadequate or no filtration equipment can be source of contamination. So my recommendation at home is to get into the habit to have these wipes, good for bacteria, viruses, these wipes to clean the surface of the toilet. Not because somebody is sick at home, but have that habit. You do it at least 3 or 4 times a week. You clean the surface of the toilet, right? The borders. That's one. Now, hand washing, of course. If you can have at home antimicrobial to hand wash, is even soap is even better. Now, if you're gonna work in the hospital and you are taking care of somebody with any parasites or any diarrhea in the gastrointestinal, of course, my recommendation, first, get into the habit of washing your hands before entering the room. Wear double gloves and wash your hands again when you finish the cleaning and you're gonna go out of the patient's room. Wash your hands before and after and wear double gloves, okay? It's very, very, very important. And with these recommendations, we have finished chapter 52 finally, and let's continue with chapter 53.